Okay, so so apologies to those of you who are relying on the recording last time. Something went wrong. I've been trying to use that lav mic so I can move around a little more. Now I'm going to try to rely on my computer, see if I can figure out what's wrong with the lav mic. New tool, new toy for this semester. In case you can't tell, I like to walk around while I talk, and this kind of contains me to being more generally in this immediate area. Okay, so I re-recorded some of the lecture, so that's out on YouTube now, corrected. All right, so we left off talking about deafness as disability, with the idea that the deaf community, depending on who you talk to in the deaf community, they may or may not perceive themselves as having a disability, right? So this is that idea that we talked about differentiating between illness and disease, right? Where we're using this idea that illness is the individual's perspective on themselves. It's their subjective evaluation, whereas disease is society's perspective, especially through some person with a social authority to declare whether you have a disability or not. And I recommend to you, I mentioned it last time, and most of you, none of you said you had seen it, but The Sound of Metal is a very good movie, and I think it's on Netflix for free, and I've got the link in the slide. But without kind of giving away the story altogether, there are some scenes in that movie of a deaf community and how they interact, and they really kind of drive home the point that within the deaf community, if you're deaf and you're operating in the deaf community, you don't feel like you are disabled. You are just like everybody else, right? And yet, there is a real debate. I had a deaf student, profoundly deaf student in my class, who I believe was deaf from birth, in one of my classes I taught many years ago now. And she asked me what my thoughts on cochlear implants were, and I'm like, all right, this is a trap. And she had very strong feelings about giving children cochlear implants. Like, she would not do that if she had a child who was born profoundly deaf. She would not have surgery done to put cochlear implants into her child, because it would take the child out of the deaf community. Because if you are born profoundly deaf and they put in the cochlear implants, your brain would then kind of grow to understand and use those inputs, as imperfect as they are. I mean, you're never going to have the same level of hearing, even if you are, even if you have these from shortly after birth. But you would be able to function in a hearing world with minor disability as opposed to profound disability, right? From the disease perspective, from the social perspective, right? And so her perspective was she would not do that. And I, as a hearing person, couldn't imagine that, but she had exposure to the deaf community and would want her child to also be part of that community. So it's a really interesting and ethical perspective. Like, should we give, so this is one of those things, like, should we give parents the right to choose whether their child who is born profoundly deaf should get cochlear implants or not? And that's a tough question, right? Because however the deaf community feels, there is a level of disability that they experience when operating outside of the deaf community. And yet, you get into all kinds of questions about parental rights, right? Like, if this is your child, what right do I, as a social authority, have to impose my beliefs about what should be medically done to your child? What right do I have to impose my beliefs about what disability is or is not on your child? Tough ones, right? And that's why we have medical ethicists out there that make these decisions. Now, I would lean towards letting the parent do what the parent wants to do, but that's one of those situations where if you don't act, and this is the problem, like, if you don't act when they're infants, their brain will as you go farther and farther into maturity, as your brain matures more and more, it becomes what we call less plastic. And so your brain, when you're a child, your brain can reshape in all different ways, right? And depending on the inputs and the environment that you're in, it forms different systems. It shapes different pathways based on the language you speak, for example. There's profound changes. Part of why it becomes harder to learn a language the older you get, because your brain is less plastic. Though how plastic, we continue to find that the brain stays relatively plastic throughout most of our lives, but it is a progression of progressively less plastic, meaning it can be molded, right? And when you learn a new thing, your brain literally changes shape. Like this is not an exaggeration. It's like it grows new pathways. So as you're sitting here studying 401 materials, your brain is in the process of reshaping. And you as younger people have more plastic brains than I do, right? And so that's why it's harder to teach old people stuff as opposed to young people stuff, just in general. So if you don't make that decision when the child is an infant and you wait till they're 18, the effectiveness of the implant diminishes greatly. And so that's where it becomes a decision that has to be made by someone, because the infant can't make the decision for themselves. And so who has the authority to make that decision for an infant, right? And that's a question, so we can set aside the cochlear implant question. We can expand that question generally throughout kind of particularly childhood, right? Because there are other questions that are currently coming up. So for example, and I don't want to step on a landmine here, I'm not going to get into the specific ethics of it, but we have a lot of discussion about trans now and transitioning. And one of the effective treatments, particularly for male to female transition, would be to use a puberty blocker, which means that it's a chemical treatment that prevents a prepubescent adolescent from going through the puberty, because we all kind of look the same up until we hit puberty, right? Like boys and girls don't look all that different except for how you dress them and cut their hair. But boys and girls are pretty much the same until you hit puberty. And then guys broaden out, right? Gain dramatically more muscle mass, big facial changes. Women have other, likewise, other processes go into play. You grow breasts, your body shape also changes in a different way. If you take puberty blockers, you don't go through that process. You can kind of short out that process and you kind of maintain that androgynous raw form if you don't go through puberty. The problem is that's not reversible, right? And it has to be done before you hit puberty. So you're talking about like somewhere in the 10, 11 years old range. And so if you have a kid come to their parent and say, I feel like my biological sex does not match my gender identity. I want to, mom and dad help me. And mom and dad go to a pediatrician and say, what do we do? And the pediatrician says, well, there's these things called puberty blockers. But the problem is that if we implement them, we can't go back. Like there's no undoing that. And so if you do that as a young man, right, as a young male, and then you're like at 15, you're like, you know what, I changed my mind, too late. You're never going to grow into the physical stature that you would have grown into. Likewise for females as well. It has a distorting effect to the maturation of your body. Now that's a good thing. You would, assuming you are, let's assume that the right thing is for people's identity to dominate their genetic endowment. Meaning, if you feel you're a female, if you feel you're a woman, but you are born male, doing the puberty blocker will allow you to look more like a female, more like a woman, than if you don't. The problem is that at 15 or 16, you're like, I changed my mind. It's too late, and your body's never going to mature. And like I said, likewise. So there's a huge ethical problem here, because what the hell did you know at 10 years old about what you wanted for the rest of your life, right? And you're in your 20s, never mind, when you get to be 50, right? So parent has to make that decision. A social authority, a physician who is granted significant authority by virtue of their medical license, right? And by the state broadly, meaning when I say state, I mean the government. So there's this huge problem that we have to wrestle with, because you've got a 10-year-old telling you something, but that 10-year-old has seen very little of life and knows very little about what life's course is going to look like. And so it's somewhere between the parent. It is ultimately up to the parent and the medical establishment to ultimately make that decision. And so there's some arguments that the parent shouldn't have the right, if the kid expresses a desire to begin to transition, then the parent shouldn't have the right to say no, right? And then there are other perspectives, of course, that say, no, it's the parent's right. And then you could say some physicians will refuse to do it, right? And so another ethical question would be, does the physician have the right to refuse to administer the puberty blockers? And so and let's say that's not for medical, like you're not going to say, let's say for now that the effects are completely predictable and that there's no risk to life as a result of implementing we don't expect that this child will develop a heart condition, for example, and would likely die as a result. So let's just assume that it will work the way we think it will work. Some physicians will just say, no, I'm not going to do that. Maybe they have religious beliefs that they don't want to do that. So should they be allowed to say no based on their religious beliefs or their personal beliefs? Maybe they don't think trans is a thing. So I don't have an answer to all that, but it's complicated. Part of the problem by the way, that I didn't know about, I learned recently about is if you give someone puberty blockers, their sexual maturation doesn't happen properly, and they may never be able to have an orgasm. So that's a kind of fundamental thing about being a human being, right? So you potentially take that away. Now, a 10-year-old doesn't know what that is, doesn't know what that feels like. And so they could tell you, I don't care. But again, that's just one example of the things you don't know that you have to make a decision about, right? So those are is trans an illness? Is it a disability? How should we treat it? Those are just another example. It's a little more complex, maybe a little more timely than being profoundly deaf. I don't have any answers on that, but it is a point that you should think about, because that gets into the realm of medical ethics, right? And this is a piece of what we're thinking about here is, what are the rights of parents? What are the rights of the child? What are the rights of the medical establishment? How much does the medical establishment have to do whatever the patient demands of them? Who should pay for that? That's another thing. That's a thing that's running through the system now. Is there are a number of trans people who are in prison, and they are demanding, because once you imprison someone, you become responsible for their health and well-being, right? Now, prison is a punishment. So the isolation, the loss of freedom, all that is part of what we call, what penologists call, those people that study prisons, what they refer to as the pains of imprisonment. It's supposed to suck. That's why it's prison, right? That's why we put bad people there. However, the Eighth Amendment says we have a right, the Eighth Amendment to the Constitution says we have a right to be free from, I'm going to watch this now. It's something like unjust punishments, like excessive punishments. So if you get caught shoplifting a pack of gum, we shouldn't execute you, right? That's the basically the punishment should match the crime. That's basically what these amendments says. So just because you've been in prison doesn't mean you shouldn't get medical care, right? There are plenty of horror stories of people who have, heart conditions who go to prison for some sort of white collar crime. They stole $10,000 from their business or whatever, and they wind up not getting medical care and they die of a heart attack. They went into a heart condition. Prison healthcare is not great, but we now have prisoners who are going in, who are saying they're trans, right? They're saying my identity is trans, like I'm a biological male, and they start asking for a variety of things, like I want to be imprisoned with women. I'm a biological male, but I want to be imprisoned with women. That's a problem. The prison system is now having to deal with. And so that's a whole range of issues. I'm not offering what should be done there. I'm just presenting this as a complicated problem. But going further than that, some of them, once imprisoned, demand that they be assisted with transitioning. That they demand testosterone blockers or estrogen treatments, they demand surgical treatment as well. And so the question is, now that we have imprisoned them and we have taken away their ability to seek out their own medical care, we have that responsibility as their imprisoner, right? As a state, put you in prison. We have the responsibility to provide you fair and reasonable medical care, because otherwise you're violating them. And so, should we pay for transitional surgeries, transitional medications for prisoners? And this is a real problem right now that's bubbling through the, never mind whether we should imprison biological males with biological females. The average male has something like 30 to 40% more muscle mass than a female does, right? And so you are, even if they are partially transitioned, this is the challenge with the trans woman who's on. You may have heard about this. The trans woman, I think she's at Penn State, and she's a swimmer, and she transitioned from male to female, and now she's breaking all the NCAA swimming records because she was a male. Now she was a man. Now she's a woman, and she's swimming as a woman, but she went through a male puberty and has 30% more muscle mass than her competitors do. So these are issues that are, cross boundaries and we get into the social recognition versus the individual identity, right? So the interesting problems and questions, and I have no answers. I'm just putting that out there as going with our idea of how does society perceive someone's conditions versus how they perceive them themselves, and then what obligations do we have going between those? Okay, so thinking about disease, presented here the epidemiological triangle. So this idea, so we're staying with disease now, really focused on disease. So social observation. This kind of classic idea of this triangle, we like triangles in healthcare. So this triangle, the epidemiological triangle, we say that disease is produced by a combination of three major factors. The host, that's the person, or animal even, but the person, in our class, who's getting sick, right? And their characteristics. So what we've seen with COVID, for example, is older people tend to be more at risk for COVID. People who are overweight are more at risk for COVID. People who have immune deficiencies are more at risk for COVID, on and on, right? There's a whole slew of factors. The agent is the thing that's making you sick. So COVID would be the agent in my example. right? But it can be other things as well. It can be pollution, other things. And then the environment. So it's combination and the environment. So contagious disease like COVID, right? The more tightly packed in you are. So if you live in New York City, if you live in downtown Chicago, you are at much more risk of getting COVID than if you live in rural Durham, New Hampshire, right? Unless you go to Libby's on a Thursday night. But otherwise, you are living in a rural area has had less community transmission, which is part of why we've seen a lot of kind of denial, in my opinion. This is opinion. A lot of COVID denial in rural areas. So, like rural New Hampshire, we have very low uptake of vaccines in northern New Hampshire. Mostly because they weren't seeing the level of, initially they weren't seeing the level of transmission because there just aren't that many people up in Bergen. Right. So you have a mix of factors, and these three factors kind of interact to make disease more or less likely. Okay, so this is kind of a neat little model. So, thinking about the individual, we can think about health behaviors as the things that we can do to improve or diminish our health. These are the things that we can do. So what's this gentleman doing that is probably impacting his health? He's smoking, right? Smoking is like, God bless, if you smoke, quit. If you don't smoke, don't start. Like nothing good comes with smoking. So this gentleman is smoking. So that's a health behavior that is negatively impacting his health. What else can we kind of guesstimate about him and his health behaviors just by looking at him? Not to be mean, but let's just what else can he control? Yeah. He's a little bit overweight. He's a lot of bit overweight, I think. Yeah. Right. So what does that say? What could he do? Like work out. Yeah. Get more exercise, diet. Right. So not to pick on this gentleman. Right. But what we're looking for now are behaviors, not characteristics. So we're not saying, at this point, we're not saying, well, he could be younger. He can't, right? He can't do anything about that. But that would definitely reduce his health risks if he could become younger. He can't do that. So we're not going to say that age is a health behavior. That's not anything he's doing, right? The fact that he's white is not anything he's doing. And then the fact wherever he's living, and actually now I'm looking at it, I think this last night, was he might actually be in a wheelchair. So he may not be able to exercise as much, but could still control to some degree. Exercise, smoking, diet, these are all things that we can control to some degree. So there are actions that we can take that negatively, that can either really negatively or positively affect our health status. Smoking is a big one, right? It's tied to virtually every bad thing. Smoking is tied directly to pretty much anything that you don't want to have happen to you. So like I said, if you smoke, quit. If you don't smoke, don't start. Substance abuse, alcohol and other intoxicants. Moderate use of alcohol has historically been proven to be actually probably good for you. There is some interesting research starting to come out about the category of drug that I'm trying to think of, mushrooms and what's the word? Hallucinogens, broad category. So the kind of LSD, hallucinogens, ecstasy, these are all what's being shown now. Some interesting research is coming out that these can be useful medical treatments. So you can microdose with the support of a coach, and it can be profoundly transformative. There's very limited trials at this point, but people with chronic depression have shown significant improvements after a series of treatments with hallucinogenics. But again, very narrow, very limited testing on this so far. You know, and oh, by the way, this is only under controlled clinical kind of conditions, not, I feel depressed. What Professor Bonnick is telling me is I should go start dropping some acid on. No, that's not what I just said, okay? So please don't do that. What we're saying is these are being done in very controlled, safe environments with a coach, and they're finding that it has positive effects. And hallucinogenics have been used for millennia by various cultures, but they have historically been used, not in recreational ways, but in like religious ceremonies where you have a lot of control. So if you think about that, like, you know, I forget which Indian tribe uses peyote, which is as part of a vision quest, right? So you go out into the desert, it's a rite of passage, and they use the peyote as part of that. Well, that's not just like, hey, let's drop some peyote and go to Burning Man, right? So this is you know, the religious controls, you know, kind of, you know, provide the cultural controls around the use of those intoxicants. So it's interest, so substance abuse as opposed to use, right, is kind of my point. Back in the day, not that long ago, if you lived in a city, so 200 years ago, 300 years ago, you lived in a city, your drinking water was often the source of transmissible disease. One of the earliest epidemiologists was a gentleman named John Snow, and not of Game of Thrones fame. And he studied a cholera outbreak in a London neighborhood. And what he discovered was there was a very popular well that people would go to pump their water because they didn't have running water, right? Because this is back in the, I don't know, 1700s. And what he started mapping where the cholera outbreaks were happening, and what he did was he tracked it back to this one pump. And it turned out that the people really liked the water that came out of there because I guess it tasted good or it was easy to get or whatever. It turned out that it was full of cholera though. So as you were drinking this tasty water, you were also swallowing down a whole bunch of cholera bacteria. What the cholera bacteria does to you is basically you die of diarrhea. It's an unpleasant way to go. Okay, so one way to, and so this is very common, right? So one way to protect yourself from cholera that they didn't understand, because they didn't understand that cholera was a germ. They didn't know what germs were in that time. All he knew was the sources of disease is this water fountain, and so let's stop letting people use this water fountain. And when they did, the cholera stopped. Right? So one thing that historically was better than drinking water was what? What does not have? What is aseptic, meaning it doesn't have any germs in it? Beer, alcohol, yeah. Beer has no germs in it because it has alcohol in it. So if you drink weak beer, you're less likely to get cholera, right? So drinking beer is good for you, within bounds, right? If you don't know, but too much beer, of course. So this is substance abuse. So funny, I'm trying to be funny with you. So substance abuse, too much alcohol is devastating. Again, like smoking, it's tied to like all the bad things. Plus, you dramatically, of course, increase your possibility of getting into a car accident, harming yourself, harming others, and winding up in jail. So substance abuse tied to a number of risks. Lack of physical exercise, we talked about a second ago, right? Exercise. Do we have any exercise science or kinesiology folks in here? Yeah, okay, great. So exercise is tied to all the good things, right? Like literally all the good things. It improves your physical health, right? It improves your but not only does it improve your physical health, like in all the good ways, like it's preventative from diabetes. It lowers your risk of cancer. It increases your bone density, which is an important thing for you women. As you age, your body tends to drain out more than men, tends to drain out calcium out of your bones. And one way to ensure that you maintain higher levels of calcium is to do impact exercises, right? And the cool thing about that is the more you have impact exercises, the stronger your bones get. So like it's important, even as you get older and maybe you can't run anymore, is to walk or do things that, or aerobics or whatever, that do things that have, impact on your bones. So it's all the good, so like I said, it does all the good things medically, but it's also well proven that it also has a positive effect on mental health as well, behavioral health as well. So like if you currently don't have an exercise routine, you need to get one. Find something you like doing that doesn't hassle you. I walk to work today. I live about a mile from campus. I walk to work today intentionally, now that it's not like negative 87 degrees outside. So with the intention that I get, a little bit of extra exercise. High-fat diet has generally been proven to be problematic, but just diet in general, right? Choices of diet in general. Improper use of motor vehicles. One of the top killers for people of your age is reckless driving, right? Especially for you young men. That's the most likely way you're going to kick it if you're at your age. Unsafe intimate relations. We've already talked about Hep C. That's the most common way that Hep C is. The two most common ways that Hep C is transmitted is through unprotected sex and needle sharing. So so there's a whole string of others. Okay? So health behaviors, these are the things that you choose to do. These are not the things you are born with, right? This is not your genetic makeup. This is not your age. It's not where you live. It's the things you choose that you have control over. All right. So now I want to talk about social determinants of health. Quick pause. You do have a couple of other things on the module for this week. One of which is a briefing that I did, a presentation I did at the National Public Health Association about my food desert experiment. So those of you who are into nutrition, I hope you find that entertaining. Does anybody recognize this place? No? Yes? Okay, where is it? It's in Dover, very good. It's on Dover Point Road. Right. So when I did my food desert experiment, if you haven't watched the video yet, what I did was, it was when I first got here, my wife was still back in Texas. She used to do these things, so I've done them a bunch. Is I decided to try a 30 days. I would only eat what I could buy in convenience stores. So one of the definitions of a food desert is you can't access a decent grocery store where you can buy fresh fruits and vegetables. You'll hear more about it in the video when you watch it. So this was the first place I shopped at as part of my experiment. So I had a chance to kind of explore all over Dover and Durham, looking for different convenience stores and what they had to sell. It's fun. So social determinants of health. One of them is, what we're getting at with social determinants of health is, on the one hand, we have the health behaviors. These are the things we can control. On the other hand is the environment that we exist in. And the environment most broadly defined as both social and physical environment. So what are we talking about when we talk about social determinants of health? We're talking about a whole slew of things, such as your ability to access education. People who have higher levels of education are proven to be healthy. People who have higher level bachelor's degrees tend to be healthier than people who have just high school degrees, high school diplomas. People who have high school diplomas tend to be healthier than people who don't graduate from high school. neighborhoods, the built environment. This is this phrase, the built environment. Does anybody know what that means? Anybody have talked about that in other classes? No? Yes, maybe? Okay. Yes, you're in the right track. So the built environment is the human created portion of the environment. So it's our access to it's where we physically live. So it includes things like do we live in a healthy building? So poor people tend to live in less healthy buildings. So you have a sick building where you have bad circulation, right? So air coming through is being circulated through vents that have mold in them, for example, right? So that's an example. That's a negative part of the built environment. But more commonly, when we start talking about the built environment, we're talking about, do you have the ability to get outside? Because getting outside is actually a really important thing for us animals, because we are animals, right? We are animals that need to be outside in our packs, getting the sun. Like our bodies, right, are programmed to absorb through sunshine, you absorb vitamin D. People in New England are notoriously low on vitamin D because it's cold here half the year. So we don't get outside as much. And if you, so getting outside is super easy. Well, that's because you live in Durham, right, where you have lots of green space to walk in. But if you live in downtown New York City, right, you may not have access to green space to go walking. You may live in a neighborhood, you may live in a space where there aren't safe sidewalks to walk on. Or your neighborhood in and of itself is dangerous. There are dangerous people in your neighborhood that will hurt you if you're out walking around. And so you don't feel safe going outside. So the built environment, the built environment in and of itself is not a bad, it's a statement. Like the built environment is itself that human beings have built, right? A good built environment would be characterized by safe sidewalks, right? Often, very popular access to public transportation, so you can walk a lot. So people in New York City do walk a lot, and they tend to, as on average, tend to be a little thinner than those of us up here in parts of the country where you drive all the time. So downtown, if you live in Boston, right? So the question is, do you have the ability to get outside, move around, get that fresh air, get exposed to the sun? So that's built environment kind of stuff. Social and community context. So this is kind of goes back. I've already kind of talked about. Do you live in an environment that's safe? First and foremost, like that's the number one human concern is physical safety. So do you live in an environment that's safe, or do you feel at risk when you're out and about doing your thing? Do you have community? Because going back to my comment a minute ago, we're pack animals. Human beings decompensate. They start falling apart if you put them in isolation. Going back to prison, we've done one of the punishments in prison is if you misbehave, they put you in solitary confinement. People start hallucinating when they're left in solitary confinement for too long. You have, they become psychotic. They lose the ability to tell what's real and what's not real, right? So that's an extreme example, but people die of loneliness. A lot of elderly people become isolated for whatever reason. They don't have family around them. They don't have people that care about them. They start to kind of come apart. This story I heard he's a leader in a federally qualified health center, which is a system that is built to take care of low-income people, right? So we have, you may have heard of Families First, or Goodwin, or Lamprey Health. These are all local FQHCs. So I was talking to this one, he's out of Tennessee, and he was telling a story of how they were covering they get paid in part based on reducing the utilization of services for patients. So they don't want you to go use expensive services. And they identified a woman who lived in an urban area who was repeatedly going to the ED, the emergency room. Almost daily was going to the ED, complaining about various random complaints. And she was inevitably discharged with, some basically like take 2 aspirin and come back in the morning if you still feel bad, which you would then do. So the ED, the emergency department, should only be life and limb eyesight. So the only reason you should go to the ED is if you think you're dying, right? Or if you're going to lose your eyesight or something really terrible, right? ED is not designed to handle simple cough, sniffles. That's meant to be done by your primary care provider. This woman kept going to the ED over and over and over again. So they finally sent a social worker to meet with her to try to figure out what was the problem. It turned out she was lonely. She didn't have any family. She didn't have any friends. She was isolated. She lived and she lived in the apartment across the street from the hospital. So one way to get lots of attention, people, showing her attention, caring about her, was to go into the ED and say that she was dizzy, or to say that her heart was pounding, or which it probably was because she was lonely. And there is a physiological connection to the mental health component there. So what they did was they started paying somebody to go visit her, right, to keep her from going to the ED. And then they started helping her find connections to, elder care and to a community center and things like that, which was much cheaper then, because if you walk into the ED and you say, I'm dizzy, they're immediately going to be like, time to put you in a CT, right? We're going to do vitals real quick, but then we're going to put you in a scanner, right, to see if you're having a stroke, because that's one of the an important indication that you might be stroking out. So they were treating her every time like she was maybe having a stroke, or maybe they would do a full workup like she was having a stroke. Then the next day she'd come back, I've got chest pain. Shit, now maybe she's having a heart attack. We're 99% sure that she's fine, but now that she's come into the ED and declared a medical symptom that could be something severe, the ED has no choice but to treat her as if she has a severe condition. And so we're talking about, the bill for a CT scan is going to be about $2,000. So, tonight it's $2,000 for the CT, $800 for the ED visit, $500 for the lab work. So she's running out like $5,000 a night. Right? So sending somebody, sending a nice young college student over to just check on her costs like $50. So it's much cheaper. This is an example of that social and community context, and it's also an example of what we were talking about before. Freedom from illness is not the same thing as health, right? It's not the same thing as wellness. And so what this organization was doing was treating her for wellness, and it turns out that's really cheap, right? It's a relatively inexpensive intervention to get her connected to the social systems. She just for whatever reason had not. I don't know the story beyond that. Like, why was she so isolated? But she was, and they were able to help her get connected to, adult daycare and things like that. If you're poor, that is a directly linked to lower health status, right? And you can follow the logic to that very quickly, right? If you're poor, you can't afford to live in a nice place. If you're poor, you probably can't afford high quality food. If you're poor, you are constantly juggling all the challenges that a middle income or upper income person doesn't think twice about. Can I make rent this week? Can I pay for my gas? Can I, buy food? If you're poor, you're juggling your very limited resources to constantly try to make ends meet right? And if any little thing goes wrong, chances are you're not eating today, or you're not making rent, and then the landlord's coming after you and banging on your door, telling you to get the hell out because they're gonna, they're gonna evict you. So if you're poor, you are dealing with challenges that middle income and higher income people just don't even think about. I don't think about making my rent payment, my mortgage. I don't even think about it. I got plenty of money. If I lost my job today, I could live for a year or two on my savings without any problem. Would want to, but a poor person is often living right at the edge, and they're constantly juggling to make everything work. And that creates incredible stress. So there's a phrase in psychology called ego depletion, right? Ego depletion, and they demonstrate a whole bunch of different ways. Trying to think. If I try to give you a complicated puzzle to do, and I don't mess with you, you can probably do the complicated puzzle. You guys are really smart. You can probably do it fairly quickly. If I harass you with a bunch of different tasks and then say, okay, now sit down and do the puzzle. If I've used up your focus already, and then I tell you to sit down and do the puzzle, you're less likely to be able to do it. Right? I'm describing the experiment poorly. But the problem is that poor people, because they're constantly juggling all these other things, they get exhausted. And so they look for shortcut ways to satisfy other needs. So one of the reasons that poor people tend to eat more fast food is because it's cheap, it has enough calories to get by, have to cook it, and so it eliminates some of the stress in your life, right? And that's a help when you're juggling all the other things in your life. So you have to, so economic stability, which I broadly kind of say in terms of economic class, right, tends to be correlated with health outcomes. Now, plenty of rich people take their money and have bad diets, right? All you have to do is go to, a nice Hannaford's and, in a wealthy, go down to the Hannaford's in Exeter where everybody's wealthy and beautiful, and watch what people buy. And then people are checking out, right? With bags of chips, cans of soda, and beer, and cake, right? So it doesn't stop people from having bad diets, but it does, but having money reduces the amount of stress. So there's a whole slew of things that may be outside your control. Or maybe outside your control that create stress on you, that negatively impact your health. One of the interesting things that fits this kind of mold is culture. And so there's an interesting website. It's called Hofstede Insights. Hofstede, I forget his first name, is a psychologist, and he did a famous study looking at cross-cultural factors. How well can you see that? So the purple scores are the United States, the blue scores are France. It's like averages. These are very gross averages. And they measure different cultural factors. And so he's got these surveys from all over the world, asking large populations different questions. So these characteristics that he explores are, the first one is power distance, which is basically how much deference do you give your betters, right? So people who you believe are higher class than you, right, or have higher socioeconomic status. So SES, so socioeconomic status, refers to a mix of characteristics that we could broadly consider class. But they roll up. Some things are, and depending on the society you're in, it kind of varies. It's income, gender, race, ethnicity, education. Right? It's a whole slew of things that kind of gobble up into what we call socioeconomic status. And in some countries, like Great Britain is a very class-based society, and so people pick up on things like your accent and can tell where you went to school, where you grew up, and they treat you differently than if they hear a different accent, right? In the United States, we have issues around race, and we've been having a lot of conversation about that. So my point here is different countries have different ways that they approach differences in class, if you will, in terms of who you think your betters are. And so the United States has very low power distance, which means we tend not to think that anybody's better than us. F you, you're not better than me, right? So the United States has very low power distance. France has, relatively speaking, higher power distance than the United States. So there's what high power distance countries have cultural expectations that you will treat your betters, differently than you'll treat people who you regard as beneath you. The United States tends to be much more egalitarian. Individualism, this is an important one. That was actually important too. We'll talk more about SES and the impact of SES. Individualism is essentially the belief that you are responsible for your own outcomes, right? So it's I versus we. So the United States is one of the highest individualism measures in the world. Other countries, so France, relatively, still very high, but relatively less. A lot of Asian countries are very low on individualism, which the flip side of that is communitarianism. So they're much more we, whereas in the United States, we're much more I, right? And that leads to particular beliefs and behaviors that we'll talk about in a minute about, responsibility for life's outcomes. In the United States, if you're poor, it's your freaking fault, right? And in more communitarian areas, it's no, it's we're all responsible for each other, So there are pluses and minuses to that. Individualism in the United States also leads to the ability to make choices like, I've decided I'm a trans person, right? And I'm going to do this. In a low individualism society, they may, the response to that might be, no, we don't approve, right? So these are relevant measures that kind of help determine the social determinants, like the social structure that you are embedded in. You can't control the social structure of your country other than you can move someplace else. Masculinity, they use this, these are older names, but they use this to refer to the need to compete and win versus the need for what he calls quality of life. I kind of think of as like need to dominate versus the need for community. So the United States, high on masculinity. Uncertainty avoidance. This is the extent to which we're comfortable with risk. So a high score means you avoid risk. A low score means you are more comfortable with risk. The United States has a long history of being a place where you come to take risks, right? People come to the United States because they want more individualism. They want the ability to remake their lives. So the United States has low avoidance behaviors for risk. France has much higher of risk avoidance. That leads to things like choices of career, for example, right? If you are a risk avoidant person, you might go to work for the government, right? You might go get a job working for the state, very stable, not going to make a lot of money, but you're not going to ever be poor, right? But if you are a more risk tolerant person, you might get into sales, right? Where you eat what you kill, right? So if you don't sell anything, you don't get any money, but if you sell a lot, you make a lot of money. If you want to make a ton of money, go into sales, right? But it's one of those things you can't, I am a risk avoidant person, right? So I don't, relatively speaking, I don't like that kind of risk. At least in financial, like in terms of finance, I'm very risk averse. I take risks in other places. Finance, I'm a risk averse person. I work for the university. I don't make very much money. I just got tenure, so now they can't fire me, right? So basically, I feel like I'm very safe now. That provides me comfort. But somebody who has much higher financial risk tolerance will be like, I'm not going to work for a measly salary from UNH for the rest of my life, right? I'm going to go out there and make a bunch of money. So this and you know, the cultural average matters, because then what gets imprinted on you varies depending on where you are in society. Long-term orientation. The United States scores low on this, which means that we tend to want results right now, right? And this is a problem with our companies, that they tend to behave in very short-term. They have very short-term targets. You'll hear on the news, if you listen to the financial news, you'll hear, you know, Microsoft released its quarterly earnings this week, and they were, you know, they were only $5.23 per share, and the market was expecting $5.25 per share. And so the share price is fallen about 27%. So if you miss, you know, if you miss your target, your quarterly target, you're dead to me, right? What have you done for me lately, right? Whereas countries that have a long-term orientation, and I would say again more, I think of like the Asian countries like China has been on this incredible march towards economic prosperity, and they very much as a country have this vision of where they want to go, whereas we are very disunited right now. And then indulgence. How likely are you to indulge yourself? And that would be like, you know, it's Friday night, I'm gonna go to the bars, I'm gonna get drinks, I'm gonna, you know, meet an attractive person of my preferred gender, and I'm going to eat the things I want to eat, and I'm going to do the things I want to do. The United States scores high on that. France, more self-control. I don't know if you guys have been to Europe. The people in Europe are not fat, right? On average. I mean, there's fat people, but like the ratio wise, like if you walk around, I was in Rome a couple of years ago, right before the pandemic. I was in Paris the year before that. The people in Europe are not fat the way that we are. Like, yes, there are some fat people, but the obesity levels in Europe are not what they are here, and so that kind of carries that, right? So cultural factors fit into that idea that we are both individuals making individual choices, and we are embedded in an environment that has impacts. The environment includes the built environment, the physical environment that we're in, as well as a social overlay. And so these are examples of kind of that social overlay that you are embedded in. So if you're in the United States, you're seeing this set of characteristics that have both good and bad to them. If you go to France, and then this website, the link is in the notes. Website is very cool. You can pick, they've got like 140, you know, all the countries. So you can do comparisons to whichever country you'd be curious to see. Right. So another psychological measure that I like to think about, and it's related to this idea of individualism, is locus of control. Locus of control has it's a spectrum, and we all kind of fall on this spectrum somewhere, where we either have an external locus of control, that all the things that the things in my life are things that happen to me, right? So the fact that I'm standing here in front of you is the result of a confluence of social factors that have led me to be here. There's not really anything that I could have done differently. I am standing here today because fate ordained it. And here you are listening to me because fate ordained it, right? So people who are far left, far left, I just want to make sure that we're both seeing it in left. People on the far left believe that your behavior is kind of guided by fate, luck, or other external factors. And those I would plug in here identity stuff, right, as well. And if you believe that, basically we're governed by fate, right, and we have relatively little ability to impact the outcome, our individual outcomes, then the logical conclusion from that is, well, then society has a great deal of responsibility for us, right? Providing for our medical care, providing for our well-being. providing us financial support. The other extreme, and I would say that this is a spectrum, and most of us are somewhere in the middle, most of us are not on one extreme or the other. The other extreme is an internal locus of control, and this person believes that everything that happens in their lives is the result of what they did, right? So if you have a strong internal locus of control, all of your accomplishments are yours, right? They happen because you exercised your prerogatives and went out and did stuff. The dark side of an internal locus of control is everything bad that happens to you is also your fault. So if you get cancer, it was clearly because you did something wrong, right? If you have an external locus of control and you get cancer, it's just, it's one more bad deal, of cards, right? It's just luck. That's the way things are. But if you have a strong internal locus of control, you start running through your whole life like, shoot, I smoked that one cigarette at that party with George back in 19, whatever. You guys weren't even born in 19, whatever, 20, whatever, and that must be why I have lung cancer now. Well, no, probably not. But so people who have a high internal locus of control really believe that they're responsible and that they can do stuff. And so people have they believe that their outcomes are their responsibility and the result of their efforts. And so they also tend to have very high levels of stress in their lives because everything that happens is their fault. Good or bad, it's all them, right? And so they tend to get stressed out, but they also tend to take a lot more action. They tend to be a lot less passive in their behaviors. So where you fall on this, where you philosophically fall on this, affects a lot of your behaviors. I've got a source for this on the notes if you want to read more about it. So that kind of fits with what we've been talking about, right? People who have a high internal locus of control are going to look at their health behaviors and say, I can take responsibility I am responsible for my health. Right? And they are going to try to some degree to affect that outcome. People who have a external locus of control are going to say, well, it's all the social determinants of health. I am what I am, it is what it is, it's how it's going to be, right? And the people they tend to have lower levels of stress, but they also tend to have less motivation, right? So it's an interesting question. I want to share, this is a concept from a philosopher named Amartya Sen. He won the Nobel Prize in Economics a while back. So you're going to get, I told you I'm a recovering philosophy major, so you're going to get a little bit of philosophy here and there. So Amartya Sen won a Nobel Prize. He's from India, and he studies economic development. And he looks at his particular interest is the poorest countries in the world and why they succeed and why they fail. And he has this concept called capability as freedom. And when he talks about it, this idea of functions, and it's the funny language, if you can get past it, it actually makes sense. When he says functionings are doings and beings, which are basically, now these are my words, these are basically things that you need to do or be in order to have a flourishing life. And so when I say flourishing, what I mean is, we're going back to that definition of wellness and health as not an absence of disease, but a wellness, a sense of well-being, right? And so we need these doings and beings. But in order to have a sense of flourishing, in order to flourish as a human being, you need to have a certain amount of economic security. You need to have a certain amount of nourishment, right? You need to have a certain amount of social support, all those things, or else you can't then kind of rock it off, right? You can't achieve the things you want to achieve. And so he says, okay, those are the things we need to do in order to flourish. And he says capabilities are the opportunities to have those things. And capabilities come both from you as an individual, but then also from your social environment. So if you were born into a favela in Brazil, right, which is like a ghetto, in Brazil, they call them favelas, violent, a lot of drugs, right? Profoundly suffering from COVID right now, impoverished. If you're born to a favela in Brazil, your capabilities, the opportunities, which translates the opportunities to pursue the functionings that you need to do, are strongly limited. If you're born to a poor family with a mother who is a heroin addict or a fentanyl addict, worse, a fentanyl addict in Pittsburgh, New Hampshire, which is up by the Canadian border, tiny little town, very poor overall. Like most of the North Country is very poor. North Country refers to kind of the upper half of New Hampshire for those of you from Massachusetts and elsewhere. Rural areas of New England are very poor. New Hampshire, prior to the COVID pandemic, had one of the highest levels of opiate addictions and opiate death in the country. So we have a lot of people in this state who are suffering profoundly, right? So if you're born into a family where mom is an opiate addict, right, chances are she, and dad probably isn't in the picture. Chances are you're hungry a lot. You probably get to school sometimes, you probably don't have a lot of love and attention. You're probably getting into all kinds of trouble. It's a very tragic situation. So the capabilities of people who are born into those circumstances are very different than people who are born to a middle-class family in Newton. Newton. Not gonna admit it, you are, right? So Newton, nice town, nice suburb of Boston. Most people that live in Newton are professionals, right? High income houses are like 800, median house costs are like $800,000, right? Schools, a lot of capabilities there, right? If you don't succeed coming out of Newton, that kind of happens. Like what you've been doing, right? Now that doesn't mean that just because you're wealthy, you don't have some suffering in your family. We all have capabilities, right? So he talks about these capabilities. So this capability set is the capabilities that you have access to that you can then use to achieve your functions. So if you're born in a favela, you're born in Pittsburgh, New Hampshire, your life chances are much worse than if you are born to a upper middle class family with a mom and a dad, or at least two parents that love you and care about you, and make sure you get a good diet and make sure you get to soccer camp and all these other things, right? It shapes who you become. So that's an interesting framing, I think, worth thinking about. So let's talk about public health. I'm going to kind of go fast here. But public health is basically the perspective, as opposed to medicine, the practice of medicine, which is focused on the individual. Public health is focused on the public, hence the name, right? So the broader society. And we're concerned with creating conditions, right? So these are the capabilities. This is the social determinants of health is a public health concept. And so we're focused, public health is focused on creating the conditions where everyone can flourish, right? That's really what it, so that's so we're trying to create at a society level better capabilities, to use the Marcus Sen's framing, right? We want to create the capability, a higher capability set. And so we try to minimize risk factors such as get you clean water. Like you don't want to have lead pipes. So one of the things that we're trying to get, I think that passed in President Biden's first bill was to get all lead pipes replaced in the United States. I know he's got some other plans for the Build Back Better thing that didn't go through yet. But what was it? What was the town in Michigan that had lead pipes and everyone was getting lead poisoning? Flint, right? So Flint is a public health disaster, right? You as an individual can't do a whole heck of a lot about your water source, but the government can. So that's why public health tends to be a government state-run process. And by state, I mean government, like at all levels. So, we don't have, New Hampshire's not a good example. We have kind of regional public health agencies, and then the state kind of overall has a public health structure. And we'll talk more about this in detail later on. But in Massachusetts, it's done at the county level. You have a county public health program. So they focus on really, if you think public health, think social determinants of health, right? That's what they're trying to impact. So kind of its definition is it's a science and art of preventing disease, prolonging life, promoting health efficiency through an organized community effort. And I'm emphasizing community, it's not an individual thing, right? Public health is a community-oriented thing. It's applying at the population level. So some things they do, they focus on prevention, so preventing you from getting sick. So they're going to get the lead pipes out. They're going to make sure that cholera isn't in your water, right? They promote health, so they try to figure out ways to get you to go exercise, because exercise does all the good things, like we said. Health promotion includes stuff like trying to help people figure out how to have a better diet. And then health protection is kind of a newer thing, and it's symbolized by a bunch of these things such as OSHA, the EPA, and others. So my point was, a second ago, I said, let's compare medicine and public health. Well, medicine, we're thinking about physicians, nurses, dentists. These are the people who are going to lay hands on you and fix you when you're broken, right? Or they're going to counsel you and help you figure out how to improve your life. Public health includes all of that, because public health does include the direct care delivery system, but it also includes kind of the broader picture of mosquito removal. When I was stationed at Fort Polk, Louisiana, which is out in the not the bayou, but it's very, very rural. They have a mosquito issue, and so periodically you'd see this truck driving down, and it would have a trailer on it, and the trailer had this machine that was spewing out this white cloud. A couple of times I was out running and I got behind the damn thing, so I'd probably get cancer at some point. But it was basically a anti-mosquito treatment, and they were treating the base because there's so many mosquitoes. Mosquitoes are a vector for all sorts of bad things, malaria in particular. So, kind of again, focuses on the individual patient, right? Medicine very focused on the individual patient, whereas public health is very much focused on the population. I'm going to post these slides for you, so I'm going to go kind of fast. I'm running out of time. When we think about preventive medicine, which is the field of public health broadly, is trying to prevent disease. Primary, so we have three levels of prevention. Primary prevention is trying to stop people from getting sick. So we're going to try to keep you from smoking. We're going to give you high quality water. We're going to build sidewalks that you can walk on. We're going to, when we rebuild our downtown, we're going to make it a walkable area. We're going to, and we're not going to have cars come in. Secondary prevention is, and this is not just public health, this applies kind of across the board, is early detection and treatment of disease. So this is when you all get to be 40, when you ladies get to be 40, it's when you go to have your mammograms done. It is when you get very unpleasant, as my wife tells me, annual exam where you do the pap smear, trying to make sure that you don't have ovarian cancer. For gentlemen, it's when the doctor feels around for your prostate, which is a special kind of feeling. Must be as unpleasant later. Probably not the level of the pap smear exam, but still pretty unpleasant. It is screening colonoscopies to try to detect colon cancer early, and so forth. And then tertiary prevention is once you're sick, we're going to try to prevent you from getting more sick. Right? So once you're sick, we're going to try to engage you in preventive activities. So we're going to try to keep a diabetic from getting diabetic neuropathy, which is a loss of what happens if you're a diabetic and you don't take proper care of your sugar levels. The the nerves in your extremities die. And so fingers and toes. Toes are the worst because you see your fingers all the time, so you know if something's wrong with your fingers. And the problem with diabetics is their wounds don't heal. So if you get a wound, it's longer to heal if you're not properly managing your diabetes. So elderly people, in particular, who also have diabetes, it's necessary to do foot checks on them periodically because they might bump their foot on something, have a wound that then opens up and doesn't heal, and then they can get gangrene and they can wind up losing limbs. So you see a fair number of elderly people in nursing homes who have diabetes who have lost limbs as a result of that. So tertiary prevention is, we know you're sick, now we're going to try to keep you from getting more. Environmental health is a subset of public health. Whoops. So most people died when in wars. So Andy, you should appreciate this. Most people died of what we call DNBIs. Do you know what DNBI stands for? Disease and non-battle injury. Disease and non-battle injury. All through human history, most soldiers died from cholera, malaria, other contagious diseases because they had poor sanitation, mostly because of poor sanitation, but just general poor nutrition, poor sanitation. And most soldiers died from disease and injuries not related to combat. It wasn't until the Vietnam War that we had more KIAs from combat than we did from disease. So disease has been prevalent and a killer in all of history. How am I on time? I got a couple more minutes here. Let's skip that. All right, I'm going to have to finish this up next time. Let me touch on, but I'm going to touch on one more thing here because you'll have some homework around it, and then I've only got a couple more slides after this. So when we evaluate health status, we'll finish on morbidity and mortality. Mortality refers to death, right? How many deaths per 1,000 do we have? So we measure these sorts of statistics in per 1,000. Morbidity is about disease. How much disease do we have? So morbidity refers to things like how many people have diabetes, how many people are obese, how many people have cancer, right? So if you remember from the video I asked you to watch with, what's his name, a Swedish guy, right? He talked about how life expectancy grew with wealth, right? There's a direct connection between wealth, social wealth, and mortality. The leading causes of death in the United States, right, overall, heart disease, number 1, cancer 2, COVID in 2020, number 3. All right, we'll pick up with this next time. All right, I think I wished you a happy weekend last time, so I was just looking forward to the weekend. But now, have a good weekend, be safe, enjoy it.